everyone. This is Chadi Alraies coming to you from NCVH 2025 from New Orleans. I'm really privileged to be with my friend Patrick Alexander coming from Michigan to talk about aorto-iliac disease and diagnosis and management. Patrick, thanks for being with us.
Thank you, Chadi.
Yeah,
thank you. It's a pleasure. It's a pleasure. No, it's an honor to be here. And aorto-iliac disease is it's a very debilitating disorder. There's a lot of patients with peripheral vascular disease, as you know, but if you have to look at the most complex form of it, it's when it involves the aorta and the iliac arteries right at the bifurcation. And so, very challenging spot to treat. One time considered kind of a no-no or a off-limit site for endovascular intervention, but I think with some of the studies and the techniques that people will see here, they're going to see that this is actually treated very well and very successful endovascularly.
Yeah, and so approach to this problem, especially if you have bilateral disease, single axis, dual axis, right radial to peripheral. What is the approach on this algorithm?
Yeah, so the approach can be tricky, and I think you have to tailor it to the patient. Traditionally we would use femoral access, and I think now with the equipment and the access sites being more utilized, and the equipment is smaller, they're slicker, they're hydrophilic. I find myself using the radial artery access, the pedal access, almost as first line versus femoral access. And success rates are very good, and complication rates are very low.
So pedal access to fix the iliofemoral artery?
Well, most of the patients will have multi-segment disease. So you find yourself dealing with an occluded iliac artery, and then the common femoral artery is occluded, and the femoral artery is occluded. And in order to preserve your runoff, you often have to fix multiple spots. So frequently we're getting access in the radial artery, usually the left radial. We're getting access in one of the pedal arteries, whether it's the posterior tibial or anterior tibial artery, and we're working our way towards each other and able to deliver the therapy that way.
Aorto-iliac disease is definitely a progression of PAD. Right. So what makes this disease progress that far without being discovered? Are we failing screening? Is it patient awareness?
I think we can do a better job of screening. Patient awareness, absolutely. This disease is happening in patients in their 6th and 7th decade of life. And oftentimes patients will tell me, I thought I was slowing down. I thought it was my arthritis, my hips. And it's not till you get to an astute physician, a good primary care, a good podiatrist, someone who says, you know what, let me check your pulses, let me evaluate you for vascular disease. You have all these risk factors, and then you start finding there's some abnormalities, and then all of a sudden those symptoms were not related to arthritis or aging, it was claudication. And so we see that so many times.
Unfortunately, yeah. And then, as you said, it's either the patient awareness or the luck of the patient being in the hand of physician who look specifically for this problem.
Yeah, absolutely, absolutely.
Final comments about importance of teaching and education for fellows, especially we're training physician, the next generation for as cardiologists and interventional cardiologists. But I feel that less focus in certain programs on PAD interventions.
Right.
Do you recommend for fellows watching us especially go to a program where they have some exposure to PAD or dedicate a full year of endovascular intervention?
We're going to see fellows that are going to want to treat PAD. They're going to want to do the intervention. There's going to be fellows that are going to want to be aware of it. And I think you need to have at least the awareness. If you're not someone who's going to want to get dirty and down in the trenches and treat, you should at least be aware and not say, my patient's coming in with an ulcer on the leg, it's not my problem, I'm the cardiologist. I think, our cardiologists these days we need to focus on the entire vascular system, even though, traditionally we're thought of as only heart doctors. Oh, you're a heart doctor, why am I seeing you? I get that all the time. When patients come in to see me for their vascular and say, I don't know why I'm here, you're a heart doctor. And I said, no, we're cardiovascular. We treat the whole system. And so I think it's very important for our fellows, our new fellows, to understand that they're going to be the leaders in the field, and they need to know the entire cardiovascular tree and the patient, and listen to your patient, examine your patient, and not rely on so much technology.
Absolutely. Dr. Alexander, thanks again for spending time with us.
Thank you.
And for
Thank
very
you.
big insightful about iliofemoral disease and the
My
training.
pleasure. My
in the corner
pleasure.
of
Thank you
PAD
so
Alraies.
much. Thank you.
Watch these videos and others on the YouTube channel. This is Chadi Alraies coming to you from NCVH 2025 in New Orleans.